Today at the National Press Club, Dr. Danielle McMullen. As President of the Australian Medical Association, Dr. McMullen will outline why it's time for a serious rethink on how to reform our healthcare system. Dr. McMullen with today's National Press Club address.
Hello and welcome to the National Press Club and today's Westpac address. My name is Tom Connell. I'm the club's president and an anchor at Sky News Australia. Our guest today, the president of the Australian Medical Association, Dr. Danielle McMullen, also a Brisbane-based GP. Her speech is entitled Underpinning Australia's Healthcare System, Strengthening the Base, Not the Facade. We've had in recent years some huge injections of cash into health, in particular from the federal government, and it is a system consistently ranked as one of the best in the world. But that old, pretty new age term of lived experience, people don't always feel that way. There's a big gap between access in particular and timely access as to whether you live in the regions and the cities, and as well whether you're private or public. Take, for example, the issue of skin cancer, the most prevalent cancer in Australia. The current recommendation is that the most serious skin cancers are seen within 30 days in the public system, in a public hospital. According to the AMA report, that is creeping more towards 90 days. When we're talking about some of the most serious cancers, including melanoma that can spread within weeks, the difference between the public system, maybe 90 days, or the private, where you might get someone within 1 to 3 weeks, can quite literally now be the difference between life and death. Before I welcome today's guest, I'd like as well to welcome a delegation of Samoan journalists who visited in Canberra and they're here today. So welcome to the National Press Club in Australia. And now for her speech and then questions as well, of course. Please join me welcoming Dr. Danielle McMullen.
Thank you, Tom, for that introduction, and thank you all for being here. Another welcome to our Samoan colleagues. I spent a few weeks there on my elective in medical school, so in Apia, so a place close to my heart. It really is wonderful to see so many of you here, to see so many people who agree that the best possible way to spend your Wednesday lunch break is talking about how to improve our healthcare system. I'd like to acknowledge that we're meeting today on the lands of the Ngunnawal people and pay my respects to their elders past and present. For generations, our Aboriginal and Torres Strait Islander patients and colleagues and friends have understood that health is about more than just the absence of disease. It's a complex interplay of physical, social, emotional and spiritual well-being. And just as we must always look after our own health, our health system also needs regular maintenance. I'll open by saying that we have an excellent healthcare system. Our balance of public and private care, our strong primary care sector, our system sustainability overall, and most importantly, our health outcomes are the envy of most of the world. But, as our Press Club CEO Morris said to me not long ago, if the AMA was ever entirely happy about our health system, we'd all be out of a job. And while we do have an excellent health system, it certainly is in need of some maintenance. I'm here today to implore us to not let our system fall into disrepair, to highlight how we could make the most of some of our best health system aspects and not fall into the trap of a quick lick of paint. If our health system was a house, would we say it has good bones? Perhaps a few rooms that are in need of a bit of repair or renovation? Would it pass a building inspection? I expect there'd be a few caveats. Here in Canberra, long dry summers and your clay soils combine to lead to cracks in houses, and over time those cracks can become structural. And then if not fixed properly, then what? If we just patch it up with a bit of plaster, a quick coat of paint and a she'll be right attitude, at what point does that house start to crumble? What about the cracks facing our health system? From my perspective, they're not small or insignificant or cosmetic. They're being felt by our patients every day and by the doctors trying to hold our system together. The truth is that yes, we have a great health system, but every part of it is under strain, and parts of it are perhaps no longer structurally fit for the demands placed upon them. We mustn't fall into the trap of just that slap of plaster. I'll start where most Australians begin their healthcare journey and where I spend most of my time, in general practice. It's the foundation of our health system. It's where issues are picked up early, where chronic and complex disease is managed, where continuity of care lives. And when it works well, general practice keeps people well and out of hospital. But general practice is being asked to do more and more with a funding structure from another era. Australians are getting older, our population is ageing, and we're living with more chronic conditions. That means that the care that we're providing to everyday Australians is necessarily more complex, takes longer, and is more dependent on strong coordination. And yet, Medicare still largely rewards short consultations and penalises the time that it takes to provide that more comprehensive care. Government's recent efforts to bring down the out-of-pocket costs for patients attending general practice have had some impact, but it's not the deep structural reform we need, particularly to support our most vulnerable. What we need is a new 7-tier Medicare item restructure that supports GPs to deliver not just the acute care, but also the chronic and complex care that we're trained and skilled to provide. We also need additional workforce supports to be able to get bigger teams into general practice and provide that wraparound care of a healthcare team working together. Our nation has a primary care 10-year plan. It was thoroughly consulted on. It values general practice as the hub of strong coordinated teams, and it's future thinking and ready for the health challenges that our country will face. So it's time we back in that plan, and a bit more on that later. Because no matter how excellent our general practice system is, we will always need our public hospitals. People with severe and life-threatening illnesses or those needing surgeries will always need hospital beds. And yet our hospitals remain in crisis. Ambulances are ramped, patients are waiting far too long for planned surgeries, and our emergency departments are overcrowded. Our staff are exhausted, burnt out, and often facing abuse just for trying to do their jobs. We hear a lot about efficiency in our health system, but that's like trying to ask me to squeeze more water out of a dry rag. There is no more efficiency to gain when we've got patients being treated in corridors, we've got people who should be discharged home but have nowhere safe to go, and when our staff shortages are at such a state that our rosters are being held together by goodwill. But the hospital logjam is not a hospital problem. It's a system-wide issue and reflects failures in aged care, disability support, community care, and overall system planning. And it's costing patients time and dignity, and sadly in cases, their lives. It was a huge relief earlier this year to finally see the signing of a new National Health Reform Agreement. And we welcomed the Commonwealth's additional funding to help our public hospitals get back on track. It followed years of advocacy through our AMA Clear the Hospital Logjam campaign. But our costings show that it may not be enough. And regardless of the funding, we need real reforms to make sure that we can tackle the logjam and really have our public hospitals operating at their peak performance. Solving the pressures on our public hospitals will take genuine cooperation and coordination between levels of government across disability, ageing, and health. It's enough fighting about the money now. We need to all agree that actually we're all on the same page, we want the same outcome, and patient care must come first. But if all that doesn't sound stressful enough, imagine the pressure on our public system if we didn't have such a strong private healthcare sector here in Australia. Unfortunately, our private sector is also facing growing challenges. Minister for Health Mark Butler often talks about the sharp elbows in health stakeholder meetings. And there's certainly been some very sharp elbows pointed squarely at doctors over the past few months. Every day in my general practice, I see patients struggling with the costs of healthcare. They're delaying care, putting things off, and questioning which test or treatment they really need most. It is a real issue. But laying that blame squarely at the feet of just doctors is a convenient misdirection. It's a look away moment, away from the more difficult and complex issues facing the sector. In case there's any doubt, let me be clear, the AMA does not support egregious billing. We've long promoted quality-informed financial consent and in fact led work with a group of other peak bodies around developing a toolkit and a guide for both doctors and patients around informed consent. What hasn't entered the discussion enough recently are the other factors driving costs for patients. Medicare, which underpins our private sector, has failed to keep pace with inflation, with wages costs, with other real-world costs that drive those gaps for patients. Public outpatient clinics are few and far between, feel impossible to find in some parts of our country, essentially forcing people into a private sector when they can't get a public appointment. And private health insurance medical benefits paid back to patients have also lagged despite rising premiums, meaning patients are paying more and getting less. Interestingly, within just 2 weeks of a report shining the spotlight on doctors' fees, Australians were told that the average health insurance premium would increase by 4.41% this year, the largest increase in nearly a decade. This premium increase is a significant blow to families already doing it tough in a challenging cost of living environment. We know many Australians have already downgraded their cover, and I fear many more will. 68% of health insurance policies now contain exclusions. Another example of Australians getting less but paying more. But this isn't just about money. I've also seen the real-world clinical impacts of these changes in the private sector. Patients don't understand the difference between a knee reconstruction and a knee replacement. Knee reconstructions live in silver, generally, and knee replacements in gold. And so I've had patients who, weeks before a planned surgery, have found out they have inadequate cover. Orthopaedic wait lists in many parts of this country are 2 or 3 years long. And that's just to get the appointment. That's not the surgical wait list. So in desperation, these patients in pain have sometimes turned to self-funding their entire surgical experience. That lets insurers off the hook. That's not fair. The challenge facing governments and insurers is whether they're prepared to address the underlying costs facing patients, rather than just finger-pointing at convenient scapegoats. Because outrage at doctors may make for some great headlines for all of the media in the room, but it doesn't make a great recipe for sustainable reform. The AMA will continue to push for a private health system authority, a stakeholder-led independent body to do the deliberate design that we need in our private health system and fit-for-purpose regulation to make sure that our private health sector is delivering high-quality, value-for-money care for Australians that's well-coordinated in our broader health ecosystem. With the challenges facing health at the moment, the need has never been greater for an independent body with the ability to withstand those sharp elbows. But of course, wouldn't it be great if we never even needed to set foot inside a doctor's surgery or a hospital? Unfortunately, we're heading in the other direction. In 2024, smoking was overtaken by overweight and obesity as the largest cause of preventable disease in Australia. And yet, we continue to treat prevention as optional, as a nice-to-have that we can do when the budget allows. The government could introduce an evidence-backed policy that both makes an impact and boosts Treasury's coffers, a tax on sugar-sweetened beverages. Backed by the World Health Organization, it's a win for patients, a win for health, and a win for Treasury, Everybody gets a win. Even our own House of Representatives Committee on Health, Aged Care and Sport recommended a sugar tax in 2024, and yet the advice of experts keeps being ignored. Maybe it's the word tax that has governments shying away from this policy, particularly at the moment. So I don't care, call it what you will, but we just can't keep kicking this can with 12 teaspoons of sugar in it further down the road. So we've just taken a tour of the house, had a look at a few of the rooms that might need a bit of repair. But what about some recent renovation attempts? We've seen some new additions spring up in our health system that just don't quite seem to fit. New doors that aren't really connected to the rest of the house. Since early 2024, state governments have been introducing NHS-style pharmacy prescribing. In fact, much broader than the NHS rules in some states. It's quick, cheap, punter-friendly? Maybe. Although if you scratch the surface of some of the consumer data, it shows that actually consumers want tight guardrails around this prescribing and not just open-ended scope expansion. Is it successful? Who knows? We're yet to see any quality evidence that it's working to improve outcomes or access, but we are concerned that it doesn't line up with our primary care 10-year plan. Is it dangerous? Again, who knows? Mechanisms to report adverse events or near misses are absent or hard to find. Of course, errors happen in healthcare. I make mistakes too. I've had phone calls from the local pharmacy questioning a dose on my prescription, and sometimes there has been a mistake. I value those phone calls. It's a really important safety step, and it's a good example of team-based care. What I don't agree with is system-wide change that increases risk and reduces double-checking, or changes that ask clinicians to make new and bigger decisions without adequate information available to them or the training to make those decisions. Now, before cries of patch protection ring out, that's not what keeps doctors awake at night. It's the many new doors opening up that fragment our health system, and pharmacy prescribing is only one of them. Another is urgent care clinics, a seemingly well-meaning policy that still needs a fair bit of work. I'm glad they're GP-led, but they do need much more integration into our health system, given that still 1 in 3 of the interactions at an urgent care centre doesn't have any communication back to the usual GP. And despite the introduction of urgent care clinics, I've just told you how our hospitals are still in logjam. So are they working? The real solutions lie in our network of more than 7,000 general practices spread right across the country, in our most rural and remote regions. With the right supports, I'm confident that general practices can deliver both the acute care alongside chronic care that Australians really need. We're seeking solutions that make it sustainable for general practices to open for longer hours. Changes as simple as recognising that staff costs and after hours happen before 8 p.m. We seek solutions that modernise Medicare rebates so doctors can properly spend the time they need with patients. And we're also encouraging government to provide more funding to nurses, pharmacists, allied health to work inside our practices and under one roof. That would improve access to care. I'm sure that my patients would value the opportunity to come and see me, or to see our pharmacist and talk about their medicines, or spend some time with a diabetes educator, with the confidence that their team was genuinely all talking to each other. At the moment, the many front doors being opened up are not helpful when they're not connected to a GP. It seems at the moment that access is the only goal in health policy. But to show the risks of access above all else, I'll share a story about a patient of mine, with permission, although I won't use her real name. It's a story that should sound alarm for policymakers and decision makers alike. Jane is in her mid-50s. She works part-time, she looks after her elderly mother, and she has a bit of asthma, but otherwise she's fairly healthy. She was getting more short of breath, and so she went to the local urgent care centre, where she was told it's probably your asthma, increase your use of your puffer. A week or so later, she wasn't getting any better, so she went to a satellite hospital, which is another hospital avoidance strategy we have up in Queensland, and she was told much the same. Again, a week or two later, she really thought maybe she was getting worse and phoned an urgent care centre and was given advice to self-treat at home and go and see them in a few days' time. And she came to see me instead. I hadn't met Jane before, but she'd been coming to our practice since we opened, and so I had a collation of reports faxed to our clinic. I could scour her My Health record and get some more health information there, so I had a bit of a picture. Although by that stage it didn't matter much. She looked awful. She could barely breathe. Her oxygen levels were low. I listened to her chest, and it certainly wasn't asthma. It was something I hadn't heard in about 10 years. But thanks to my broad clinical training, I knew what I was hearing, or rather what I wasn't hearing. I couldn't hear any air moving in and out of her left lung. So I phoned around and I managed to get her a same-day CT scan and an X-ray. And unfortunately that showed what I suspected. This wasn't asthma at all. Jane had widespread cancer, and her left lung space was filled with cancerous fluid. Telling someone that they have a severe and life-limiting illness is awful, but it is also an enormous privilege. My role as a GP is to walk with people through the darkest moments of their life and help them navigate the system and find their way through it. Thankfully, against all odds, Jane's actually doing really remarkably well. But she was keen for me to share her story as an example of the gaps in our health system, how patients can fall through them, and the power of having a usual GP. Because Jane did nothing wrong. She got sick, she sought healthcare. She wasn't getting better, she sought more care. But what she couldn't know, and what she didn't know, was that the doors she was opening weren't connected in the back. So no one got the full story. No one got that moment of, hang on, this lady's been in a couple of times. What am I missing? What's really going on here? A system that's designed for acute minor illness didn't pick up something more serious. And that's what we're talking about with continuity of care. That is the value of continuity. I'm not magic. I'm not going to pick something up always on the first time either. But by seeing someone for both the small things and the big things, by attending the same clinic, even if it's a different doctor a few times in a row, we're trained to put those pieces of the puzzle together and make sure we get there as quickly as possible. Jane's story demonstrates how this approach that there's so many front doors and no wrong door, while it's a well-meaning policy direction, can be confusing and at times can be dangerous. So when we renovate, let's make sure that it's in line with the home design that we actually want to see, not a lick of paint and not an ugly addition that doesn't quite connect. Today, I'm releasing our 2026-27 pre-budget submission. It's not a wish list. It's a set of practical, costed, evidence-backed policies that recognise a simple truth. If we want our health system that works for patients, we must fund it to work. We must modernise Medicare with a new 7-tier item structure. We must invest in connected multidisciplinary care. We must fund after hours in general practice so that emergency departments aren't the default option. We must actually reform our public hospital funding to clear the logjam and get patients the care they need. We must reform private health insurance to make sure it's delivering value for money and transparency for Australians. We must take prevention seriously and implement a tax on sugar-sweetened beverages. We must value continuity of care. And to do all of that, we must build a workforce that's sustainable and ready for the future. A collaborative and coordinated workforce that's genuinely working together, where yes, we maximise everyone's skills, but we do it together. we must think very carefully about changes to scope of practice. It may not be the governments of today who bear the ramifications of ill thought out policies. It's our patients who'll face the highest cost. Australians rightly expect a health system that's there when they need it. And doctors expect a health system where they can work safely to deliver high quality care to Australians. Right now, too often, neither of those is being met. But if we act now, we can undertake the renovations and repairs that our health system needs. But act now, we must. Thank you.
Thank you, Danielle. I might start on the urgent care aspect, which I think ties in with after hours GP funding. So we keep getting told that we're struggling to get enough numbers to go into general practice. Therefore, is the funding really the issue, or we still not have enough doctors? Because whilst the example you highlight is a pretty sad one, it seems to me more an advertisement for do urgent care better. Have automatic follow-ups, have My Health actually working. Every time I tell a doctor, yes, tick to My Health, it seems to go off into nowhere. I'm not sure how the system works, but that model is still needed because our lack of GPs, it's just maybe it's not being done very well. And if it's not being done well, is that an argument to scrap it or do it better?
Yeah, it's a great question. The good news is now with Share by Default, if you tick the My Health record box, it does go somewhere now. It didn't for a while, but we do now get those reports, and so do you on your app. But the question around urgent care and general practice more broadly. So general practice has been oversubscribed now for a number of years. There are doctors who want to be GPs. We're now, I believe, into about our third year running of an oversubscribed program, despite government investing in more training positions. So there are more GPs in the works. There is still a shortage. We do still need more, and we need to make sure, particularly in rural and regional Australia, we have enough doctors on the ground. But you're right, it's about coordination. Urgent care centres are part of our health system now, and they're likely here to stay, but it's about making sure that the information is following patients where they need to be, and that it's not a replacement for having a usual GP. That's a real crux of particularly people with chronic illness, but as I've demonstrated, we never know when that chronic illness is about to start. In general practice, providing after-hours care is difficult in that it is sometimes as simple as after-hours Medicare rebates. The increased rebate back in your pocket as a patient doesn't kick in until 8 p.m. But anyone who runs a business knows that you're probably paying your nursing and your reception staff and your other staff increased costs from 5 or 6. So there is a funding gap there. So we've long been calling for adjustments to that time period to be more realistic at 6 p.m. As at least a first step in helping general practices be able to open longer.
I'm always wary of the promises made just before an election. The headline one from the government was $8 billion into bulk billing. We had calls at the time to say longer consults are the issue. You've said that again now. Are we far enough in to say that that wasn't the best use? If anyone could have spent $8 billion back then, this was not the best way?
Look, our restructure of Medicare items, which we do think would give patients a fairer set of rebates, cost $4.8 billion. So it was a cheaper option then. The government clearly had in mind the initial out-of-pocket cost for patients, and we have seen rates of bulk billing increase. But what we are concerned about is that is at the shorter end of consultations. It may drive, the incentive then is to still keep the consultations as brief as possible.
And ramped up even more, arguably.
And so potentially have multiple consultations to achieve the same outcome. Where we know, again, people travelling to get to healthcare, my patients often have a list of health needs by the time you've made time in your life to get to the doctor. If you can manage multiple issues in the one consultation and have a fair rebate for a longer consultation, you deliver better health outcomes.
How's that pitch going? What's the reception like as we
head towards the budget? Look, we understand the fiscal environment is constrained at the moment, but health really is the best investment, and so we continue to push government to direct their money where it can make the most impact. Money doesn't grow on trees, we recognise that, so let's spend it wisely.
Dr. Google's been fired, but Dr. AI is now looming large. How much do you Have you noticed the change? Because all the talk has been since sort of summer, how much AI has improved, people looking at accessing it. Are you noticing people come in and say, I know what the issue is and this is why?
People are using it. And I think even before AI, there was a bit of a shift away from going to the doctor with a list of symptoms and us helping you find the answer, to already people were Googling and trying to come up with the answers themselves. AI has amplified that. I think we just have to recognise that it's happening. But again, if you've got a trusted relationship with a usual doctor, it takes a bit longer because sometimes we need to undo what AI has said or lean into it and explore it together. So it's, as a profession, we're learning how to adapt to that new environment. It sometimes is helpful, but the risks are there as well because there isn't the quality control of AI or social media, and so the message really is to be wary of what you're seeing online and have a regular doctor who you trust to kind of fact check that with.
Go to some questions from my colleagues, beginning with Ron Misen.
It's always a scary prospect when the question you had in your head as you stand up is then asked by the person before you. I'll ask two sort of points here. You raised concerns around pharmacy scripts, and I'm just wondering, could you expand on what you think the guide rails need to be there, or is there simply no place for it? And also, Morris mentioned Mark Butler is up here next week. It's likely that a big part of that is going to be a discussion around the NDIS. What advice does the AMA have for him in terms of the task that he has on the NDIS?
Yes, I'll take the second one first. Obviously, the NDIS, there's been a lot of talk in the media about needing to contain costs there. Supporting Australians with disability is really important, and allowing them to lead normal, happy lives and participate in the community. As we seek to rethink, reshape how the NDIS operates so that it's sustainable into the future, our focus is also on how do we make sure these people get the health care that they need. There's been a lot of talk recently about thriving kids, and certainly that space, young children with a single domain delay or with mild to moderate autism, their GP is often the first port of call, and there's been a real lack for some years now of community level supports or even access to private allied health. So as we reshape NDIS, we really do need to make sure that state and territory governments are investing in their outpatient clinics and programs and therapies there, and that our private sector does have capacity to look after people from a health perspective for their health needs, as well as it's more a disability sector question around how we continue to make sure people have their home supports. On pharmacy prescribing, we work in collaboration with pharmacists every day, and they do an incredible job of helping patients through their medicines needs. I would love to see more home medicines reviews and more in-practice, non-dispensing pharmacists in our practices. There's been trials of that right across the country. We've shown that it works and yet struggled to get ongoing funding. What we're concerned by with the state-based trials is now we've ended up with a bit of a dog's breakfast of rules right across the country. Depending on what state you live in, there's a different set of rules, which is particularly difficult for border communities. And while strong delegated prescribing authorities, as we're seeing emerging with registered nurses, we're open to conversations about how that could work to improve coordinated access to care for patients. We are worried that some of these quite broad autonomous prescribing models don't have that link back to a usual overall care provider, and that even when you ask most patients, those with a chronic condition want a regular doctor to be able to be part of their care team and working with them about their chronic care needs.
Thank you.
So given it's happening anyway around the states, would it be worth a federal government or an attempt at a federal approach? Obviously, I'm not saying you should tick off anything they say, limited guidelines around scripts and wanting it to go into their GP and the information, but should the federal government just say, well, this is happening now, how do we make it happen?
So it is challenging. Poisons legislation is state-based, which is, we live in a federation and there's always a number of, this is an issue of where it is a state-based legislation, hence why we have a difference in every state. There is a process underway at the moment through the Pharmacy Board looking at some of the requirements around pharmacy prescribing, and we're engaging in that process to be and aiming to be constructive in that so that there is clear cross-sector understanding of what are the guardrails, what is in the interests of public health and safety, and make sure that patients are well cared for throughout this.
Simon Gross from Canberra IQ.
My question's about how we should treat children and young adults who present with gender dysphoria. This is a fast-moving, evolving area, both in medical and legal circles. I went into the AMA's position paper page and drilled down, and I was expecting to find something, but I got down to 2023 and there was nothing. So does the AMA have a position on this?
So the AMA does have a position that providing that people with gender dysphoria and LGBTQIA plus patients and transgender patients deserve to be treated with the respect and care of anyone else in our society as well, and including adolescents and adults with gender dysphoria should have a healthcare team that's there to explore their health needs and provide them with evidence-based care according to their health requirements.
Evidence-based care is a bit contentious in this area. What do you mean?
So it is at the moment. It is an evolving space in both the medical and legal fields, as you outlined, and that's where. So our current AMA policy is that doctors should be keeping up to date with as much of the evidence as best we can, and providing patients with that wraparound care. And again, it's, as I've outlined throughout the speech, it's not just the clinical care, but also those supports and a care team that understand and support the patient, regardless of which clinical outcome they end up with.
Thank you.
Next question, Julie Hare.
Thank you very much for your speech. I would like to ask you for your opinion on the emergence and growing growth of online specialist clinics, such as those that deal with weight loss and prescribe Ozempic, those that deal with pain and prescribe marijuana products, and those that deal with tobacco addiction and provide legal vapes. They all have doctors who need to sign off, but they never have a human interaction. It tends to be just an email exchange. Could you maybe talk us through your attitudes towards these and the MAA's position on it?
It's an excellent question, and another example of where our care system gets fragmented. These are a relatively novel pop-up, and I think have been running away ahead of the speed of regulation, and even to a degree sort of community and profession sentiment about, again, what do we want the guardrails here to be? We've come across instances where people have been getting, for example, support with weight loss through an online clinic, not disclosed that to their usual care team until the day of surgery, and suddenly the anaesthetist finds out that the patient is on these medications which do affect an anaesthetic. So there are real-world harms from a disconnected system, and again, it's driving this sort of on-demand consumer level of healthcare rather than what we see as more supportive of long-term outcomes, is having that more steady approach, a usual care team who understand the breadth of your health issues, and at least if you're referred through to a specialised clinic, there's communication back and forth so everyone's on the same page.
But isn't part of the problem here that these are profit-driven clinics, that it's actually about the money and that there's big corporations and big money investing in them?
Yes, it does depend on the specifics of certain business models, but yes, we are concerned that there is the rapid rise in online-only single-issue health services, and don't feel that they are conducive to that wraparound broader healthcare that Australians actually need. In some of these business models, there is a significant degree of profit, but there's also a big variety. Online is not all online. We know telehealth is a strong, is now a permanent part of our healthcare system, and telehealth with your usual provider is quite different to an online consultation with some of these other online services.
So what should the government or regulators do? I mean, do you have an opinion on that?
So regulators are working, and a range of these clinics operate outside of Medicare, and so our traditional mechanisms of regulation are challenged by this. There is work happening at the Department of Health through the TGA, a range of regulators meeting to try and grapple with the issue, and the AMA is of course engaging with that work to make sure that safety is first and that we're not putting profits before patient care.
Thank you.
Telehealth has been a great convenience that's come out of COVID. One example I'll give to you though, book an appointment, get a test result there, but it's not released until you do a telehealth and you're told everything's fine. 1 minute later, the appointment's over. Is that a misuse of telehealth, do you think?
So that, in fact, that landscape is shifting. So throughout this year, there is an increase in, again, what I mentioned before, share by default, where when you have a pathology test and soon a diagnostic test, at the same time as that's released to me as the doctor, you're also able to see it.
There's not that delay that used to be there.
No. So for most tests, for some critical tests, there's still a 5-day delay for safety reasons. No one wants to find out themselves online that they've got a cancer, for example. So there's been careful work with the profession to think through those issues. But you now get your results the same time I do. And so it's trying to optimise the use of consultations for high quality, meaningful care.
Next question, Francis Vegalipa from the Journalists Association of Western Samoa.
Thank you. It's an honour to be here, guys. Thank you so much for having us. My question would be, Samoa's healthcare is very sensitive topic, and I'm sure you're aware of this since your last trip. And the feeling is that there isn't enough budget allocated to the healthcare system. So my question is, what does Australia do to ensure the budget is sufficient and effectively being used?
That's a good question, and I think no matter the size of your budget, we all complain that there's not enough for health. But we are privileged in this country to have had governments who do believe overall that healthcare is an important part of our economy, and that by investing in health, you invest in your population. You keep people at work, you keep them contributing to the economy. Anytime they think about forgetting that, the AMA is right there to remind them that healthcare is an investment. We don't see it as a cost, but it is increasingly difficult. We're here, we have new technologies that are quite expensive. There's a lot of pressure on government to spend quite large amounts of money on smaller new devices or new technologies, which are really important for some patients. In other parts of the world, it may be that you actually need your government to spend on relatively cheap interventions, basic hospital care, primary care, vaccinations, and the global landscape there is challenging at the moment, especially internationally. There's conversations about the value of some of that preventative care, which I think is really heartbreaking. So we stand beside you, any help you might need, but it's just continuing to push that prevention, general practice, primary care, they're the cheap interventions, relatively speaking, but can make such a meaningful impact to your population to reduce diabetes rates, reduce the complications of that, and keep people healthy and at work.
Thank you.
Thomas Henry from The Australian.
Thank you for your address. You questioned whether urgent care clinics were really working. There are some figures that suggest these clinics are taking some pressure off emergency departments. So when you refer to the logjam, where in the public hospital system is that? And if urgent care clinics aren't the right vehicle, what is?
Good question. So you're right, there is some data showing that Category 4 and 5 presentations to emergency departments in some areas where they're near an urgent care centre might be decreasing. So that's things people turning up to emergency with minor injuries and illness. When I speak to my emergency department colleagues, that's not what's causing ambulance ramping, clogging up the system. Most emergency departments do have, in fact, often a separate whole wing with a nurse and doctor and team to run rapidly through those Cat 4s and 5s. It's severely unwell people that need to be in hospital that's causing our hospital logjam. It's not people turning up unnecessarily. And part of that, in some areas, it's we need more capacity. We genuinely need more hospitals. In other areas, it's because we can't discharge people back to aged care or disability care or safely to home. We've got people sitting in hospitals who are medically safe for discharge. They don't need to be in a hospital anymore, but they've got nowhere safe to go. And they're spending sometimes years in a bed that then someone else can't get into.
Corey McLeod from Innovation Oz.
Thank you very much for your address. I wanted to ask a little bit about Medicare reform. We're seeing an increasing amount of technologies that enable patients, particularly those with chronic disease, that are being monitored and treated outside of the clinic at home. What is the AMA doing, or what are your views to support changes to the Medicare benefits schedule to allow and reimburse clinicians to deploy and utilise these technologies?
Yeah, it's another example of why Medicare, as it's structured at the moment, isn't fit for purpose. It requires that you're sitting face to face in front of me, and ideally for as short a time as possible. That's not modern healthcare. Remote monitoring, care at home are fantastic innovations, and it's why we support the primary care 10-year plan, which has a plan in it for blended funding. It's quite difficult to do all of that in a fee-for-service model, not impossible, but it's why we support a blended payment model where government could provide, in addition to the MBS, some block funding, both for the team-based care, but also for some of that non-clinical time. The coordination it now takes in general practice when people have these large teams or complex illnesses or are doing remote monitoring at home, it's actually, I spend at least an hour, sometimes 2 or 3 a day, looking through results, reading reports, collating that information. That's all unfunded time in our current scheme, so adding to it with these sort of programs is not sustainable currently, but we are working and have both in our 10-year plan and it's already in the government's 10-year plan to have more blended funding to allow that sort of care to happen.
Thank you.
I was waiting for someone to ask about the sugar tax, so I'll wade in. I'm curious. So I get that theoretically it might change behaviour. You go down the supermarket aisle, there's usually something on discount. The home brands are pretty damn cheap. You're talking about maybe it's $1.50 a litre for soft drink if you really want to get it at that price and then drink it at work or home or whatever. How big would a tax need to be to actually shift behaviour? Because that's not much money. Even if you double the price of that, if someone really likes the taste of that fizzy pop, they might keep having it.
So internationally, the evidence would speak otherwise, that a tax in the order of about 40 cents on a can of soft drink does change behaviour at the checkout. And particularly for the Australians who would benefit most from the change. Some of us who might buy the odd bottle of soft drink as a treat and it's not in your weekly supermarket list, it may not make a big difference, and these are treat drinks. But for people who have huge volumes of sugar-sweetened beverages in their diets as a regular staple, particularly in the current fiscal environment, that level of change does make an impact and encourage people to make healthier choices at the checkout.
How would sugar replacements work?
So in our modelling, the sugar-free, so the sugar replacement non-sugar varieties are not affected. Similarly, we've not included fruit juices and flavoured milks. There are some other models around the world that do. We've made it as easy as possible for government and gone with the bare basics of your sugar-sweetened soft drinks that have no nutritional value, and still we're hitting the roadblocks.
Yeah, and on the replacements, how confident are you that if someone starts having a lot of that, there aren't other impacts? I mean, I just sort of feel as though if something tastes a bit like aluminium, maybe it's not very good for you. Not official medical advice, but that's just my vibe on some of these replacements. Is that
obviously our health message is that water is your best option, and we are lucky in Australia that in the vast majority of our country we've got safe drinking water straight out of the tap that's close to free, and so that's the consistent health message. Our overall goal is not to replace one very unhealthy option with another, option that's still not the greatest thing, but a choice between the two and ideally reduction in intake is better than where we're at now. We just can't afford to continue consuming the billions of litres of this stuff that we drink every year.
Once you get beyond that, it's what we eat as well. So would that be the next? Does that just get trickier, the burger tax?
Oh, still don't get put further things in front of our policy that we're struggling with. No, food safety. So there've been some positive advances there this year. Health star ratings. So food agriculture ministers earlier this year expanded the health star ratings to make them compulsory on foods, and we're really proud of that work and that decision, because for too long it's been optional, and companies then of course only put them on the products that they were proud of. So now consumers will have more information on the front of packets to help them make choices in there.
And from someone that occasionally makes bad decisions, I'm struck by how cheap the big multinational takeaways can be, the discounts they offer.
Yeah.
Is that something that would be in your target? That might be simpler to do rather than go, let's increase the cost of whatever the burger is. If it can't be, you go into some of the apps and it's 30, 40% off and you literally cannot eat healthily for less. Is that the sort of thing that might be easier to target discounting rather than tax?
Look, there's a range of options, obviously, that could be explored, and sometimes we often get thrown, well, why this option, why not others? A tax on sugar-sweetened beverages has long-standing international evidence, and we're lagging the rest of the world. That's not to say it's the only thing that would work or could work, and there's plenty more work to be done. We've also got to look at the availability and cost of fresh fruit and vegetables and lean meats across the country, particularly in regional areas and in some of our Indigenous communities. It is impossible to get something fresh, and the fuel crisis is only going to amplify that. So it's not the only piece of work, but it's one that does need to happen.
I do eat well as well. It's just occasional things, I promise. Sarah Porter from Australasian Pharmacy.
Thank you, Dr. McMullen. There have been many changes recently in scope of practice across the health system in Australia, from GP prescribing for ADHD to people getting vaccinations at their local pharmacies. Given that, how can doctors and community pharmacies work together to make sure there is no wrong door for patients across Australia to get healthcare in their community when and where they need it?
I think actually on the ground, GPs and pharmacists have been working really well together for a long time. And I often get the feedback that what ends up in the newspapers about, at policy level, what appears to be two groups butting heads is not the experience on the ground. And I would reflect that. Like our local pharmacy, you get to know the pharmacist across the road, and it is about that individual collaboration and being confident to pick up the phone both ways and check for an idea if I'm not sure about a medication and interaction, calling that way, have the confidence to call back if they were questioning. And we can't, that will remain important. I don't think there's a digital technology that can replace that trust that you have between professionals working together. But at a policy level, we do need to keep patient safety front of mind. There are some mechanisms through digital tools that we can improve the information availability to both parties. But along with that needs to be an accountability framework. It's all well and good for both people to have all of the information, but who's responsible for it, including the patient? And I think that's a live conversation as we see more consumer access to care to who's responsible for the information that's there. And so what I think would help is strong consultation on changes and processes as they happen. Ideally not having that done through real process, not political decision making and knee-jerk reactions. And there is some of that underway, but it's getting back to those basics. Let's make sure we have the frameworks right, the guardrails right, a shared understanding of the scope changes, there we go, and really being on the same page.
Thank you very much.
Nick Stewart from Ability News.
Following up on my colleague Ron Mizen's earlier question about the NDIS, with the NDIS system, we have a series of rules. So if, for example, you're over 65, even by a couple of days, as is the case here in Canberra, we've had someone who can't actually qualify for the NDIS, even though in every other way, apart from that regulation, they'd be eligible for it. Equally, we've had the explosion at the other end with Thriving Kids, where people are shopping for, quite appropriately, for diagnoses that are looking after them. Is part of the problem with the whole NDIS system that we actually need to break down that regulation, make sure that we're getting back to a situation where we have actual treatment for particular conditions, and so that we don't move away from the supports, but rather move away from the bureaucracy of that sort of system?
Yeah, I think it's about having a clear understanding of what the NDIS is there for and what it's not there for, and making sure the other arms of our care economy are also supported. So you're right, because the NDIS has been quite well supported, relatively easier to access for some people. At the same time, we haven't seen the same investments or growth in our aged care sector, or often in healthcare and preventative care and that wraparound team in health. So as we have a conversation across the country about the NDIS. We also need to make sure people are not left unsupported and that we do strengthen aged care supports. We need people in their older years to be cared for at home or in aged care facilities with the dignity they deserve. And as I mentioned before, at the other end of the spectrum, our youngest Australians need access to that high intensity therapy that often can help kids to catch up and participate to their full potential in mainstream schools and work. So across that lifespan, as you say, this isn't about cutting things, it's about making sure that we are delivering the cares where they're needed across the system and not just in one scheme.
You also referred to the enormous growth of healthcare premiums for private healthcare. Do we need to look at a situation that is completely new now, where we actually reinvestigate this whole question from first principles, rather than saying, oh, we've got this huge healthcare, Medicare industry, and we need to look at it again?
Look, the balance of public and private care is what makes Australia's healthcare system unique and world-leading. So we will always need that balance. I am concerned that Australians are dropping their level of cover, are inadequately insured, and it's been some time since we last did that big review into gold, silver, bronze. It's worth questioning, is that still delivering the care that Australians need in a way that's sustainable for insurers? I don't know if there's them in the room, but they're starting to kind of wonder as well about, well, how do they deliver care to a population who's only buying the high-risk product, like the high-cover product, when they really need it? So that conversation needs to happen to make sure that we still have a private sector into the future.
New hospital opening up, or open, I can't remember if it's about to or has already, but ear, nose and throat, and it's privately run with zero gap, $0. Is that actually the solution, that the private health insurers will go, well, if we're going to exist, we need to actually change and become more entrenched in this, running hospitals, whatever it might be? What do you make of that? Because that sounds to me, it's an excellent result that people would be almost shocked to hear, I think.
Well, I think people are often shocked at the big stats, because actually 97% of private surgeries are done at known or no gap rates. And that's from obviously the medical perspective. People still may face their excess for hospital costs, or there's pharmacy and imaging costs. And so patients do deserve that transparency around what's happening with healthcare costs. There is a balance there. So yes, ownership of hospitals, I'm not sure which one you're referring to, but there's a range of ways hospitals can be owned. We are concerned if private health insurers continue to increase their ownership of service provision, that does blur the lines between, are you the funder or are you the care provider? And in Australia at the moment, we are lucky. Our insurers do, by and large, they are hands-off funders and trust clinical autonomy and high quality care to happen. In an environment where health insurers own more of that care environment, there is an innate risk that they will be tempted to drive that care in certain directions, that you use own providers, own locations, and then patients are either covertly or overtly pulled into a system without the range of choice that Australians have come to deserve. So our overarching is private health insurance must remain choice for patients and clinical autonomy.
Isako Matuaina from TV9 Samoa.
Thank you so much for that very informative speech, but back in Samoa, people are saying that real changes are needed in our healthcare system. I do understand that you also have your own fair share of challenges, but as a country with a healthcare that is more developed than ours, in your perspective, what could be the challenges or the areas that an island nation like Samoa would have to prioritize on solving first, so that one day we will have to get to a point where we will see real reform in our healthcare?
Yeah, it's been, I must admit, it's been a few years since I was there, but I expect the health issues are still similar, that many of our Pacific neighbours have high rates of diabetes, difficulty accessing even primary care, and going to health conferences around the world, that is where you can get the best outcomes for your investment. Again, in Samoa with outlying islands, maybe in Apia there's health clinics, you've got the large hospital there that provides good care, but even on the other islands it's difficult to get GPs But it's family doctors. You have a medical program there, which is fantastic. You can train your own doctors, but keeping them in Samoa, encouraging family medicine, and the basic investments in prevention and health promotion, whether it's healthy eating, healthy activities and exercise, and all of the things that we spend, even here in Australia, most of my day talking to patients about eating, sleeping, stress, and eat, sleep, stress, and food. Well, I'm losing one. Diet, exercise, sleep, and stress. That's my. But it's the basics that no matter what country you're in, primary care and that basic preventative healthy lifestyle is the cheapest way to a high-quality healthcare system.
Thank you so much.
June Ramley from Daily Strait's unable to make it, but has written in this question: there are reports of Australians withdrawing from their superannuation to pay for dental treatment. What does this say about gaps in Australia's healthcare system, and what reforms would you recommend to improve access to affordable dental care specifically?
Yeah, so dental care in Australia is a real challenge. Obviously, it's not my area of expertise. I'm not a dentist, but we see it in general practice that people desperately need dental care, but they come to us because they can get an appointment with a low or no out-of-pocket cost to try and tide them through with some antibiotics for an infection, for example. But I can give them that, but I can't fix the problem. And dentists can, but we have a real challenge getting public dental services. They're really limited, and the gaps are quite large. So all I can say on that is it does have an impact on people's health, not just their oral health, but your systemic health is related to your dental health. If you can't chew, you can't eat easily, your risk of infection, people with heart conditions with poor dentition are at more risk. Like, there's a range of systemic health risks to poor dentition, and we would implore governments to support better access to dentistry for Australians who need it most.
It's a powerful line that Medicare essentially covers your toenail but not inside your mouth, which probably most people have heard, but nothing changes. You just resigned that it's a terrible part of our health system design, but it won't change?
Look, I think it will. It takes a government with guts to make a big change like that, and it's not cheap, and you'd have to talk about who and where. There are obviously some schemes for children. There are some publicly funded through our state health systems. There are public dental schemes, so it's not that they don't exist, and occasionally you can access them, but certainly more work could be done for other low-income earners in particular who are struggling.
Ron Meisen from the AFR.
Me again, hello. A bit more prepared this time, thankfully. Tom, you didn't take my question, thank you. Two parts I want to ask you. The first one is, you've come to the government, you've said this is our budget plans. The government, you've acknowledged the government's in a very fiscally constrained environment. Do you have any ideas for offsets that could help pay for some of these things, particularly in the, I think someone called out someone there, maybe that's an opportunity.
Yeah.
And then also, you obviously talked about the tax on sugary drinks. As an expansion of that, I'm wondering, I think the AMA has called for the Health Star rating to become a mandatory thing across all products, but there's also concerns around that being gamed, not used appropriately, people swapping out sugars for sweeteners and fats for other things, and you end up with some, I mean, you just walk down a supermarket aisle nowadays and you see some very strange comparisons there. Is there a risk in making it compulsory that you end up with some adverse outcomes, and what kind of changes should we see in that healthcare rating system to actually make it worthwhile for consumers?
Yeah. So in terms of the offset sugar tax, it's about $1 billion a year. I mean, that's not small change.
It's a revenue thing, though, not a saving.
But they can spend it on health if they choose to. So there is revenue to be gained there, which could be reinvested back in the health sector. Certainly, that's where we'd be pushing for it to go. And we do think it's about investment in our smart investment in the health system to make it sustainable. And so if we work smarter, we can contain growth in costs. I think the risk of doing nothing is that our systems continue to cost more and more and more. Again, back to the house analogy, if you do a bit of a rubbish job fixing it now, you've got a bigger, more expensive problem down the track. So if we don't make the investments we need to improve our health system now, when we're just setting ourselves up for failure down the track, not for savings. Health star ratings, so yes, they've been made mandatory, or they will be made mandatory, which we celebrate. Of course, then the next step is make sure they're appropriately regulated and that people aren't trying to dodge around in circles. Generally, stick to the edge of the supermarket with your fresh fruit and vegetables and frozen ones if you can't afford fresh, and then you don't have the problem of being able to interpret the labels. But I understand that the shiny, colourful packaging, and we all make questionable choices from time to time, being able to have more of that information on the front of pack helps. But yes, there are a range of sort of ingredients going into food that if you can't pronounce it, it may not be food. And so it is that next step. Food safety and food regulation and health doesn't end with mandatory labels. It's a necessary step to give consumers more information. And then the next step is let's make sure it's being used appropriately.
Would you support more explicit warning labels? I got a fantastic bottle of some kind of Mexican chili sauce the other day. It didn't have a health star rating, but it had an explicit warning after I Googled the translation that it contained a high amount of sugar for the overall product. And I thought that was a really interesting way of approaching it. Is that the kind of thing, I think there has been a discussion that perhaps more explicit warnings could be a better system than health star rating?
There you go. I haven't seen that one before. I will have to find it and work out which country has put sugar warnings on their labels. You've given us a new idea. I think it's, nutrition is complex, and it is about not demonising a particular thing forever. Like it's sometimes food, and there's a whole lot of education that needs to happen with the community continually about how do we lead a healthy lifestyle, what foods are regular everyday foods and what are sometimes foods. And I know we've all apparently been taught it since we were yay high, but there's never enough. But yes, I haven't seen that one, but now I'll be scouring the aisles for foreign labels and
for the next speech. Thank you.
Yeah, I have learned if it's colourful or 50% off, it's probably no good for you. We appreciate you coming down today. It is nice and close to Parliament to have one more knock on the door of Mark Butler. But ladies and gentlemen, please thank Danielle McMullen.